So I decided to go with hopefully people will pick up on a friend type of theme. And this is going to be, it's purposeful. I thought it would be nice, short, and sweet. All the problems that I pose theoretically have solutions. And hopefully we'll have some laughs along the way. So kind of just laying the groundwork for what I'm going to talk about. I'll talk about underdosing medications, kind of talk about allergies, and I'll touch on infusion kinetics in the ED. I promise there'll be no math involved, but just kind of some things to consider. So starting off, I really hate to say it, but a lot of the meds that we use in the ED, and certainly our most critical medications, are some somewhat based on weight and just thinking about the meds that we use on our day to day. So things like intubation meds, antibiotics, anti-epileptics, they are largely, if not completely, based on weight. Um, and the dosing recommendations, oh, sorry, are all pretty much, yeah, based on weight. The emphasis for sure, while in my training, has always been on the harms of overdosing medications, but I think in these very acute situations, underdosing can be just as detrimental. So over the last few years, some studies across the nation have tried to shed light on this particular challenge, especially as it relates to patients in the pre-hospital setting, which then winds up in the ED, and then of course in our ICUs. What they've identified is that the patients at most risk or like highest risk for underdosing are those that are obese, those that are critically ill, so thinking sepsis, on some form of renal replacement therapy, so hemodialysis, and pediatrics. I would also argue that elderly patients are at risk just because of their body habitus being small and then also their renal function. So we should really care about this big concept of underdosing medications, not only because it can lead to things like treatment failure, adverse effects, and of course we get things like inadequate concentration, but especially in really severe cases like status epilepticus or sepsis, we know that treatment failure leads to poor outcomes and increased mortality. So how do we fix this, right? I think it's totally reasonable to ask for a weight. I know in any patient room that I'm in, if there's not a weight documented, I try to ask for one. I think also it's really low stakes to start practice guesstimating weights. Even if it's something as simple and low stakes as being under or over 70 kilos, I think that's a great way to start. And of course, you guys know you can ask your ED pharmacist if you have somebody available. One of the best pieces of advice I got in my training, as soon as I said I was interested in EM, was that I should start guesstimating weights. And it's pretty much served me through. I like to think I'm pretty good at it, and I'm sure my other EM colleagues are really good too. This is just a quick reference, just going through some of the big medications and adequate dosing. Anybody that's worked with me knows that I will almost always go for a loading dose. And if there is a dosing range, I usually practice and hedge on the higher end of the dosing range in the emergency department. The two things that I do want to point out on this slide, though, are particularly the dosing for Pseudomonas coverage. Realistically, 4.5 is going to get us where we need to go, and you can infuse it over the 30 minutes. The 3.375 grams, it's only beneficial for Pseudomonas coverage if it's infused over 4 hours. And that just goes to the pharmacokinetics of this antibiotic. Time over MIC, so the longer that we infuse it, the longer that time is over the MIC, the better killing it's going to have for Pseudomonas. And then the other thing, it's really small, but it bugs me every time I see it, is thiamine dosing. It's always, the doses of 50 milligrams are really not doing us any service. So for Wernicke's encephalopathy, it's going to be 500 milligrams IV. If we're just thinking like simple alcohol withdrawal, then honestly, 200 milligrams IV is totally fine, but please get rid of the 50 milligrams. So moving on to allergies, this is also a kind of button issue for me. Um, we're really bad at documenting allergies in the chart. And unfortunately, this is something that haunts a patient for their entire healthcare journey. It sets them up for these really crappy antibiotics and kind of complications from that. Um, and a lot of this could really just be avoided by asking one simple question, and that's, what is your allergy? Um, that right there kind of helps us differentiate between a hypersensitivity reaction, an intolerance, or just something like really silly. We know that penicillin is what's often documented, and really what it's been found in studies is that patients that have a penicillin allergy listed in their chart, less than 10% actually have a true allergy to the medication. And then unfortunately, cephalosporins and carbapenems are kind of linked by association. And so what that leads us with are really suboptimal medications, especially in terms of antibiotics, really suboptimal coverage. And then you have an increased risk for MRSA and C. diff infections and other kind of terrible adverse effects. So there's actually this study that came out in 2018, and it was in the UK, and it found a link between penicillin allergies and patients with increased MRSA and C. diff infections. So just again, highlighting this. So how do we fix this? Given this kind of expose of penicillin allergies in literature and increased drug resistance and superinfections, which all lead to increased healthcare costs and lengths of stay, there's been a real push for hospitals to kind of come up with a solution and do more. So this is seen by developing desensitization protocols and skin testing protocols. Um, do I think we're going to really do that in the ED? Not realistically, although theoretically with our boarding times, you probably could do like a graded challenge. But I think the simplest and easiest thing we can do is just asking one simple question when the topic of allergies come up, and that is, what is your reaction? So this one is kind of a little out there, talking about infusions in the ED. I think we're not used to managing them for a long period of time. We're more comfortable with IV push and sort of single dose IV piggyback medications. So thinking in terms of an infusion is not really part of our, like, we're not wired for it. Yes, we have things like heparin and insulin drips, but those are kind of like very heavily protocolized. And what I really want to focus on is more along the lines of analgesic agents, sedative agents, those types of trips, especially as our acuity and boarding times increase. So just really quickly, how many half-lives does it take for a medication to reach steady state? It's 4 to 5 half-lives for most medications. So just thinking of our post-intubation meds like propofol or fentanyl, anytime that drip rate is changed or titrated up, you really have to think in hours, not minutes, for an effect to really take place. Propofol is a little tricky just because its PK is it's biphasic, but initially while we're starting these strips in the ED, that half-life is probably about 30 to 40 minutes. And so we're talking anywhere from 2 to 4 hours before we see the true impacts of that drip. I think our natural tendency, especially in the emergency department, especially when it's these kind of highly acute situations, is to just really crank up the rate on the drip, instead of doing this stepwise approach. And this is just where bolus doses can be helpful. So, spoiler alert, there are bolus doses available as long as we're using the right order set, and I believe we are. It can be helpful again in those first few critical hours in the ED when we're really trying to manage our patient and get them adequate sedation and pain control. And the doses, the titration frequencies, the parameters, all of that stuff is spelled out there in these order sets and are kind of begging to be given. So really my suggestion kind of moving forward is we get ourselves comfortable with these order sets. We get our nursing colleagues comfortable with them, and we start utilizing these bolus doses. I've got references. This, like I said, this was short and sweet. I'll go ahead and open it up for questions if anybody has anything.